Hi there, we're going to be talking about the blood today. So blood itself, remember, is a connective tissue. Oh, there we go. The liquid portion of the connective tissue is considered the matrix, and we call this plasma as well. We'll talk about what plasma is made up of in a little bit. The cellular portion of blood is made up of white and red blood cells, which we'll get to also in a bit. Now, whole blood, in general, we have anywhere from 4 to 6 liters of blood in our bodies, depending on how big you are. And it makes up 7 to 9% of your overall body weight. So depending on how hydrated you are, water, of course, will be in your tissues, but it's also in your bloodstream. So that will change your body weight depending on how hydrated you are. Normal blood volumes or blood fractions, blood plasma is usually about 2.6 liters, and the cells, or the formed elements, make up about 2.4 liters. So if you look at the composition of blood, in our body, we have, all these other tissues and fluids in our body. Blood makes up about 8%, right? Not a lot, actually. If you take a sample of blood itself, 55% of it will be plasma, and 45% will be the cells, the formed elements. Now, that's in a normal, healthy person. That's called the hematocrit. Now, these are approximate values because different people are going to have different hematocrits. What is important in these two fractions? We'll get to that, to the hematocrit, hopefully in just a little bit. Let me get a color. Let's try purple today. Now, plasma, remember, our liquid portion, is made up of 7% proteins. The proteins consist of albumins, which are proteins that keep water in your blood. Let's just put it that way. The globulins, which are antibodies, some of them are a few other things. Fibrogen, which it helps in blood clotting, and prothrombin, which also helps in blood clotting. 91% of blood is water. So that's what I mean. If you're very hydrated, you're going to have, normal body weight, but a good portion of that's going to be water. Now, blood plasma is made up of other solutes as well, ions or salts, sodium chloride, potassium chloride, magnesium chloride, nutrients, which will be your biological molecules like other proteins, in addition to the albumins, globulins, and so forth. But it'll also be sugars, of course, our salts, proteins, fats that float around in our system. We have waste products like urea and nitrogenous waste, gases, CO2 and oxygen, and then we have other substances, which we're just going to call regulatory substances. Don't worry about what those are called or what they are right now, but they're things that do jobs in our body. They could be like hormones. Now, how about the formed elements, the cellular elements? Platelets, we have a lot of platelets out there, okay? Platelets are the cells that are essential for blood clotting after we get a cut. The leukocytes are also called white blood cells, okay? White blood cells are leukocytes. Of the leukocytes, there are basically 5 different types: neutrophils, or differentiated types, I should say, lymphocytes, monocytes, eosinophils, and basophils. Now, why do I say differentiated? There are steps from the white blood cell stem cells that lie between. So you have a stem cell, and then you have a step where you have an undifferentiated cell, and then eventually it'll become a white blood cell, one of these flavors of a white blood cell. But right here, some of these undifferentiated cells, they're not going to be doing anything. They're just in the process of, I guess you could think of as developing, growing up, differentiating. Red blood cells are called erythrocytes. Okay, that's kind of the anatomy word for it. Most of the formed elements consist of erythrocytes, and of course, that's because our bodies need a tremendous amount of oxygen to operate. So, what are some basic statistics about blood? The blood itself is slightly alkaline, anywhere from a pH of 7.35 to 7.45. Blood is not usually acidic. If it is, you're not well. There are about 14 million units of blood donated annually. Stored blood can be maintained for about 6 weeks. So once they take a blood donation, they pretty much try to ship it to where it needs to go and use it pretty quickly. Plasma volume expanders which are usually proteins like albumin, help maintain blood volume after what we call hemorrhaging, after losing lots of blood for a short period. Okay, if you've hemorrhaged for a short period, like let's say you had surgery and you lost a lot of blood during the surgery, one of the things that doctors will do is give you blood with extra albumin in it. That helps keep water and maintain blood volume. Why is that important? Blood volume plays a big part in blood pressure, right? And so how do you feel when your blood pressure drops? Not good. All right. So maintaining blood volume is a big deal, especially after somebody loses blood after something like surgery. And then we have blood typing. The blood typing system that we use is called the ABO and RH classification system, and we will get to that soon enough. So let's first start with the blood cell types. All right, we have our erythrocytes, which remember are red, oops, not a B, RBCs, red blood cells. Okay, red blood cells are important for oxygen and CO2 transport. They carry much more oxygen than CO2. CO2 actually gets dissolved in plasma much more effectively than attaching to red blood cells. Now, white blood cells or leukocytes. Okay, you have your neutrophils, which are part of immunity in terms of phagocytosis. If a dead cell or a bacterium is in your body, neutrophils will interact with them and consume them. Eosinophils, which help defend us against parasite. They can phagocytize parasites. Basophils, inflammatory response. Basically, what are these things doing? They can make heparin, okay? And what is heparin? Heparin is a blood thinner, right? And they're definitely involved in inflammation. We have two types of lymphocytes here, the B and the T. B lymphocytes, are important in antibody production, and so this is purpose number one. The other purpose is for immune memory. Immune memory, that's an M. Immune memory is a way that our body, once you're exposed to something, your body remembers that, oh, hey, that made me sick. I'm going to remember that so I can defend myself against it next time. So there are the lymphocytes come in two flavors, antibody producing and immune memory cells. They're actually called memory B cells. And these would be called activated B cells. We'll get to that later. T lymphocytes are a part of the immune response, and these can also be called killer T cells. T cells are the ones that are killed in, or destroyed, I should say, in an HIV infection. So the HIV virus hunts down, destroys T lymphocytes, and as T lymphocytes go away, you no longer have these immune surveillance cells going around looking for invading pathogens. Once your immunity or your T lymphocyte cell goes down, well, once the T lymphocyte cell count goes down, then the individual has acquired immunodeficiency syndrome or AIDS. We have monocytes, also part of the body's defense. We'll maybe get into more details about that in a little bit. Thrombocytes, which are huge in blood clotting. Thrombocytes are actually, these are not white blood cells. Okay? Thrombocytes are your platelets. I should have made that more clear. And then leukocytes are kind of undifferentiated white blood cells, also involved in immune defense. Okay, blood typing, the ABO system is kind of interesting because, and I would draw a big picture out on this, but I know I have pictures in a few minutes. There are two different types, I'll draw it anyways. There are two different types of carbohydrates that can, well, there are a lot of carbohydrates that can be on the surface of a red blood cell, but the two that are important for our purposes right now are type A and type B. What you have is a protein, and on the end of the protein is a carbohydrate that's going to be modified so that it has the A configuration, or you have a red blood cell that has the carbohydrate modification that has the B conformation. And when I say conformation, that just means shape, okay? Now, some people who have type A blood have just, PE, type A, have just the type A, what we'll call antigen on the surface of their red blood cells. Type B, same thing, except for you have the B, right? Now, one of the things that's interesting is, oops, let's make a B there. To get type A or type B, you have to have the chromosomal combination, right? Alleles that give you type A, or we'll just say type I. It's absent. So this is for type A. These are supposed to represent chromosomes, folks. Okay? The other allele, same gene, different allele, is going to be type B, or again, absent, nothing there. I equals no carbohydrate modification. Okay? So you can get type B that way. Now, in order to get type A, you can be A, or AI. Type B is B, homozygous, or heterozygous, BI. Now, in order to get type AB, what do you have to be? Well, let's first look at the surface of the cell. You'll have both carbohydrate modifications, A and B. And if you look at the allele composition, the individual will have type A and type B. Remember, you have two alleles, or two chromosomes, with two different alleles, one from each parent, one from dad and one from mom. Okay? Same thing over here. Now, type O is interesting. Type O has the protein, okay? So this is AB. Type O has no carbohydrates, so their allele combination is II. Okay? So we'll get to that in a minute. Here's our AB blood. Type A and B antigens are on the surface. Oh, I forgot to mention the antibodies. I'll get to it in a minute. Type O has neither. All right. One of the things that's important, I thought I put the table in here, but no. So you have type A, B, type AB, and type O. Okay? Now, one of the things that our body does is it produces antibodies against the opposite type of blood. So this would be, we would call these, that is antibodies, the little fishy looking thing there. Type A makes anti-B antibodies. Type B makes anti-A antibodies. That makes sense because they are kind of defending against each other. That's the way I thought about it. Type AB, though, because the person's body has both antigens on the surface, no antigens are made. Okay? Type O, geez, that one's crazy. Both anti-A and anti-B are made. So, when somebody donates blood, all right, what would be the most beneficial type of cell? All right, let's look at how the blood cell, like what it looks like, okay? Or at least my version. Type A, remember, has A all over it. Type B has B all over it. Type AB has both, right? Has both. And type O doesn't have a carbohydrate modification. It's basically naked. So, if you give somebody who's a type B blood type A, it makes anti-A. So it will attack and kill or agglutinate the type A blood. Not good. Agglutinate means to clot. So if you're type B and you get type A, your blood will clot in your blood vessels and the individual will die. Same thing with type A. Type A makes type B antibodies. The type B antibodies stick to the type B blood cells, causing agglutination. Type AB, you can get by. AB can receive anything because it doesn't make any antibodies, okay? So we call type AB the universal receiver. Type O is the universal donor. Why? because it doesn't have the carbohydrate A or B modification on the surface. I will post a video showing you guys a better demonstration of how this works. Now, what about the Rh system? Rh is a totally different antigen on the surface of red blood cells. So let's say you have somebody who is A positive. They have the A carbohydrate modification, but then they also have the Rh, not Rb, the Rh factor as well. So this would be an A positive individual, okay? Now an A negative individual has just A and no Rh, okay? Rh factor, don't worry about what it does. It's just another thing on the cell surface. Rh positive blood, the Rh factor is present. Rh negative blood, the Rh factor is gone. Now, what's the big deal with this? If you are Rh positive and you're a woman, that can be a problem. Or I'm sorry, if you're Rh negative, my bad, and you're a woman, your body makes anti-Rh antibodies along with, so let's say you're A negative, so this woman would make anti-B antibodies and anti-Rh antibodies. Don't worry about how that happens, okay? How does the body know to expect B or Rh? Don't worry about that. If a woman who is A negative has a child with an individual or becomes pregnant from an individual who is Rh positive, the child will probably end up with Rh positive red blood cells in their system, and that can be a problem during pregnancy, all right? We don't need to go into all the details, but that's why they screen for Rh positive or Rh negative. Usually on the first pregnancy, it's not that big a deal, but on the second pregnancy, mom's body, the Rh negative woman, already has been trained against the Rh positive fetus if the father has Rh positive blood themselves, all right? And so in that case, the woman's immune system starts attacking the fetus and the fetus may not survive. So that's a really bad deal. So that's one of the reasons they want to know if somebody's Rh positive or negative, a woman for pregnancy. And this is called Erythroblastosis Fetalis. This occurs when an Rh negative mother carries a second, it's always the second. On the first birth, it usually works out okay. But on the second Rh positive fetus, the mother's Rh antibodies react with the baby's Rh positive cells. Remember, mom is Rh negative. If the second baby is Rh positive, then you'll end up with Erythroblastosis Fetalis. Here's a nicer picture showing you the recipient blood and donor blood agglutination patterns. So if somebody has type O blood, remember there's no antigen on the surface, their body makes anti-A and anti-B. So type O can only receive type O, all right? Only. Oops. And so that's what this panel is showing. Normal blood. Agglutinated blood is clotted blood. So over here, somebody with type O blood, if they receive type A, B, or AB, because they make both A and B antibodies, they'll end up with agglutination and serious problems. Type A can receive type O because everybody can receive type O, universal donor, right? Type A can also take type A, but not B or type AB. Type B can take O or B, but nothing else. And then type AB can take everybody because they don't make plasma antibodies to A or B, right? Because they are A or B. Okay, so that's the blood typing, the situation with blood typing. Again, I'll post a video to show you guys how blood typing works and what agglutination really looks like. Let's move on to plasma. Plasma, again, is the liquid fraction of blood minus, of course, the formed elements or the blood cells. Remember, there's water, lots of dissolved substances, which are the salts, the sodium chloride, magnesium chloride. I like this, foods. That's going to be your biological molecules derived from the food you eat. Definitely about a little bit of oxygen travels in blood plasma, about 3%, and about 5% of total CO2 travels around in blood plasma. So what are we looking at? Oops, in this picture here. in this picture, what we're looking at is what we're going to call a hematocrit. What they do is they take a sample of just whole blood and then spin it down in a centrifuge so that the heavy items sink to the bottom and the lighter items, I know it's light, L-I-G-H-T, but the lighter items stay up top. The liquid, let's say liquid, stays up on top. So usually you have the solids sinking to the bottom. Okay, so the plasma is always going to look kind of goldish or straw colored. This little buffy coat right here are going to be white blood cells and platelets floating around in the blood. This buffy coat will have a different density and be larger if somebody is sick, because what happens when you get sick? You have a proliferation of white blood cells, which is really important to fight the infection. All right, so the buffy coat is a bunch of white blood cells and platelets. And then the red parts, the stacked red blood cells. The hematocrit is the total blood volume and the red blood cell volume. So hematocrit equals RBC volume divided by total. Basically, it's the percent of volume made up of blood cells, of white blood cells. So let's talk a little bit about what we're going to find in the plasma. The most abundant in plasma are your albumins in terms of the proteins, which again has a lot to do with keeping water in your bloodstream. The globulins, which are antibodies. Fibrogen, clotting, and prothrombin, also a clotting protein. If you get rid of the clotting factors, fibrogen and prothrombin, we then call that serum. All right. Liquid serum is important because somebody may need, let's say, globulin treatment, globulin therapy. Serum contains lots of antibodies, which are your globulins. And so if somebody's very, very sick and their immune system's not functioning properly, you can take a serum donation from somebody who has overcome that particular disease, especially if it's an infection of some sort, and that individual will have serum antibodies that can defend them against the disease. So with COVID-19, for example, people who had COVID-19 already have elevated levels of anti-COVID-19 antibodies or globulins. So we would call those anti-COVID-19 COV, anti-COVID-19 antibodies. If you collect serum from those individuals, you can take that serum and treat somebody who is just getting sick and help defend them against the disease. It's a really nifty trick. All right, so we'll get that back to more of blood plasma and what it's doing in a little bit. Formed elements, lots of red blood cells. We talked about the numbers, you know, most of them are 4.2, 6.2 million in blood, white blood cells and platelets. Where are these things made? In the red bone marrow, what we call a myeloid tissue. Basically, the red blood cells live in the stem cells live in the red bone marrow, and the lymphocytes, the monocytes, the erythrocytes, all are formed there, and then they break off and get into circulation inside of bones. Now, there are other lymphatic tissues like the lymph nodes, the thymus, and the spleen, which can also help stimulate the formation of lymphocytes or white blood cells. And monocytes to some degree, but the lymphatic lymphoid tissues in the bone are by far they make the most red blood cells for sure, and quite a lot of the white blood cells in your body. Now, what is super special about red blood cells? Red blood cells in mammals actually don't have a nucleus. They're a concave disc. We call it biconcave disc because it kind of caves in the center. The center is thinner than the edges are. What that does is it increases the surface area of the cell and makes it much more efficient at carrying oxygen. They're really tough. They're flexible. When red blood cells pass through capillaries, they pass through usually in single file. And let's think about the capillaries in your feet while you're standing. Well, those red blood cells can squeeze through those capillary beds, delivering oxygen to the tissues and kind of bend and bounce around because they're very flexible. the cytoplasmic organelles are also mostly shed before the cell leaves into circulation, the red blood cell. Red blood cells live for about 120 days. They do not have mitochondria. They basically live off of glycolysis. They live off of blood sugar. It's pretty impressive. But, you know, really, they don't contract or anything. They don't need tons of energy. They just need to float, right? They don't catch oxygen and push it off. Oxygen passively attaches to the hemoglobin on the red blood cell or leaves the hemoglobin. So we'll talk about that in a little bit. But hemoglobin is the red pigment made from iron that makes red blood cells appear red. So most other, stepping back for a second, blood disorders and blood cell disorders have a lot to do basically with making too many cells. So there are diseases where the body can make too many red blood cells or too many white blood cells. The red blood cell overproduction is called polycytemia. What ends up happening with polycytemia is that the oxygen carrying capacity increases tremendously in the body, but it's because you have a dramatic increase of red blood cell numbers. Now, the problem with this is that, excuse me, it seems like a great idea. You'd have lots of energy, lots of oxygen, but red blood cells are very, very sticky and they tend to clot. So with an individual that has polycytemia, their hematocrit, or that volume, if we go back a few slides, may go up to 60%. See, this is an individual with polycytemia. At a certain point, it becomes called polycytemia vera, which is cancerous polycytemia. And usually this happens because of a cancerous transformation in the stem cells that give rise to erythrocytes in the red bone marrow. Signs include increased blood viscosity or thickness. When somebody bleeds, their blood is really dark, dark red. Slow blood flow, and what we call coagulation, blood clots. Lots of hemorrhages can occur, mini strokes. Hemorrhages in the vascularization of the eyeball actually is very common when blood pressure goes up. And there is a huge distension of blood vessels, which leads to hypertension, which means that the heart itself can become enlarged, and the blood vessels associated with the heart can become stretched out because of this larger blood volume. And it's a larger blood volume because you just have way too many red blood cells. What is the treatment for this? It's actually really simple. Blood removal, phlebotomy. This is one place where the old, medieval doctors had it right. Someone with polycytemia definitely benefits from blood loss. Another thing that they'll do is irradiation or chemotherapy to slow down red blood cell production, to try to knock out those cells that overproduce erythrocytes. Now, anemia is the opposite problem. This is where an individual has too few red blood cells, or the red blood cells are abnormal. The red blood cells may not have an adequate amount of hemoglobin on them, or the red blood cells can be defective in their shape. So normal hemoglobin levels are between 12 and 14 grams per 100 mils. Low hemoglobin starts at 9, below 9, all right? If an individual has hemoglobin levels below 9 grams per 100 mils, that individual has anemia. How can you tell? Actually, you can just look at the color of the blood. If somebody has below 9 grams per 100 mils of hemoglobin, their blood actually looks more orange and less red. What are the clinical signs? Lots of fatigue. Tons of fatigue because oxygen is not being actively carried well by red blood cells because there's less hemoglobin in each red blood cell. Skin pallor, the person looks pale. If you look at somebody with anemia, underneath their fingernails, they actually might look a little tinted blue or really, really white. Very weak, faintness, lots of headaches, and there's a compensation by the heart and respiratory rates. The heart typically will have a higher cardiac rate. The heart will beat harder because the body is begging for oxygen, and the heart gets that stimulation. It's like, oh, we got to get oxygen out there. I better work harder. Respiratory rate goes up. Your body, you start hyperventilating. The individuals have issues with cardiac and pulmonary rates because the body is starved for oxygen. Another red blood cell disorder is called sickle cell disorder. This is a picture of a sickled red blood cell, and as you can see, it kind of has this, well, they call it a sickle shape. A sickle is it's a tool that farmers used to use to cut wheat. It's the thing that you see the Grim Reaper carrying around at Halloween, okay? The sickle, he comes after you and cuts you down in life. Let's just talk about the cutting down hay and wheat, okay? Because cutting down somebody in life, I don't like that idea. It's going to happen, but whatever. Moving on. So sickle cell disease is definitely a lot more serious because, A, it's a genetic disease that can be transmitted from parent to offspring. It causes what we call blood stasis. The blood clots because these red blood cells in this sickled shape become very, very sticky. And it ends up in causing what we call crisis because sickled red blood cells, A, are not very good at carrying oxygen, so they have a low oxygen carrying capacity. B, this sickled shape leads to fragility in the red blood cells, and the red blood cells can basically fracture and break it during circulation because they're very fragile. And C, these red blood cells typically will be torn apart by the liver or the pancreas very quickly because they're dysfunctional. It affects 1 in every 600 African American newborn children. It does tend to be in a higher proportion in African Americans because African Americans can be traced back to Africa, and this occurs in very high proportion of the population in the African areas where there's a lot of mosquitoes and malaria. We can talk about that when you take my Bio 9 class, which is Introduction to Genetics. Now, the white blood cells. This is the one that when I was in undergrad, I was just like, why do I need to know this? They all look the same. They're purple. Well, sort of. They're purple because we stain them purple. But white blood cells, typically, they don't look white. When you see them floating around in the bloodstream, like we looked at in those hematocrits, they look like a white fluffy layer, that buffy coat. White blood cells, when you take them out of circulation, you put them on a microscope slide and you stain them with this purple dye, show granules or a clear cytoplasm. Okay? In Bio 16 and in Bio 18 at Merced College, when you get there, we're going to go into more detail talking about the granulocytes and agranulocytes. These granulized cells, the cytoplasm that looks grainy, the neutrophils, eosinophils, and basophils are the granulocytes. The lymphocyte and monocytes, I mean, the lymphocyte like basically has so little cytoplasm, and it's not grainy, that that's part of the agranulocytes, and the monocytes are also an agranulocyte, and they all do different jobs, which we talked about before. So the general function of a leukocyte or a white blood cell is to protect the body from microorganisms, which are bacteria. By phagocytosis, they eat them, or leukocytes can protect the body by making antibodies. Those are going to be your B cells. White blood cells or leukocytes can change in number depending on somebody's, I guess you'd say, infection status. A low number, the lowest number that's normal would be about 5,000 per millimeter cubed of blood per volume. A high number would be 10,000. So leukopenia is a measurement of the total number of cells below 5,000 in an individual's blood. So leukopenia, like anemia, means that you have low white blood cells. So leukopenia is low white blood cell number. Okay, remember anemia is low red blood cell number. This doesn't happen very often. It does happen when disease is happening or when an HIV/AIDS infection occurs. Leukocytosis, the total number of white blood cells, is over 10,000. This happens often when somebody has a bad bacterial infection. And it's also found in individuals that have white blood cell cancer called leukemia. So leukocytosis, one of the first things they're going to do if somebody has an elevated white blood cell count or leukocytosis is first say, okay, does this person have an infection? Treat them with antibiotics and see if this goes down over a week. If not, then they start looking at the possibility of an individual having leukemia. So what are these tests I've been talking about, these counts, these cell counts? A differential white blood cell count is a test where they count the number of white blood cells in whole blood, okay? And it measures the proportions of each type of white blood cell in the sample. So the eosinophils, the basophils, and so forth. And so let's talk a little bit about the granulocytes and agranulocytes. If you have an elevated granulocyte or agranulocyte number, then that's going to tell you what type of infection you might have. So again, the granulocytes, the grainy looking ones, let's go back here. Here are the granulocytes. Okay, I'll just put G for granulocytes. And the agranulocytes are on the bottom. So your neutrophil, eosinophils, and basophils look grainy with that purple dye. And the agranulocytes have a clearer cytoplasm. These are the monocytes in peripheral blood. They can be called macrophages and crawling around on your skin. And then you have your lymphocytes, which are B and T lymphocytes. We didn't designate those. Let's come back here, right here. But these can be B or T lymphocytes. Okay, so let's look at the functions. The neutrophils. The neutrophils make up the highest proportion of white blood cells in any fraction of blood in a healthy individual. They're phagocytic. They go around searching for just junk in your system, dead cells, bacteria, and they just eat bad stuff. The monocytes are the largest of the leukocytes. So go back and look at that picture again. They're really aggressive phagocytes. They eat cancer cells. So believe it or not, in your short life, you may have already had a cell that's become cancerous, but it did not turn into cancer because a monocyte recognized it as cancerous and ate it. And the monocyte just moved along. So monocytes are really important cells in our body. They help suppress cancer because it can happen anywhere in your tissues. They can also eat larger bacteria. So some bacteria are larger than others. That's something that you would learn in microbiology in Bio 20 at Merced College. But those monocytes really love going around and just attacking large bacteria, which might be found in the lungs or the digestive tract. And monocytes basically are mostly always phagocytic. Eosinophils, not quite as phagocytic. They don't attack general large things from the outside in the environment. They tend to target parasitic worms and other small parasites. Eosinophils also kick off proteins associated with allergic reactions. So eosinophilic asthma is a condition where when somebody breathes like pollen from the environment, eosinophils in the lungs start kicking off, or exocytosing lots and lots and lots of histamine. Eosinophils make histamine galore. Histamine causes inflammation then in the lungs, causing an asthma attack. So eosinophilic asthma happens when these eosinophils in the lungs just start making histamine, and that causes an asthma attack. Now the basophils, those guys are related to what we call mast cells. Mast cells also can make histamine in tissue spaces. We don't need to go necessarily into where they live all the time, but they can be in your sinuses, things like that. And like I said, they make lots of histamine, which again is related to inflammation. So in your sinuses, the basophils, if you inhale pollen and the basophils interact with them, then the basophils can start producing histamine, which is going to give you a stuffy nose. And so basophils, in addition to that, also make heparin, which is an anticoagulant, which is really important because what the basophils are trying to do is balance the histamine reaction, the swelling, with circulation, heparin, to ensure that new white blood cells can come into the area where the infection is happening. And then our lymphocytes are B and T lymphocytes. B lymphocytes, remember, can do two things. You have those that make antibodies. So we call those types of B cells plasma B cells. Okay, so here's your plasma B cell. And they make your globulins. Okay, you have the memory B cells. And the memory B cells remember the antigens or the pathogens that an individual has experienced in their life, either naturally or through vaccination, so that these memory B cells can convert into plasma B cells really, really quickly if you re-encounter that pathogen again. So for example, if you get a flu shot every year, you're being exposed to some component of the flu virus that your B cells will be trained against, and you'll form a memory of that virus. If you are exposed to that virus, your memory B cells will convert to plasma B cells and start making antibodies to tag and kill that virus. What does the killing? The killer T cells. Let's make them black or kind of dark purple because they're, they're tough and they go around killing things. So killer T cells are going to find the antibody that the plasma B cells spit out. So let's say here is a bad pathogen, okay? Give him some ugly looking mad eyes. I'm such not an artist, right? So on the outside, this guy, he has proteins on the outside looking for cells in your body to latch onto and infect, okay? Just an ugly virus. Well, these plasma cells are going to have things on the surface that will fit into this little shape. Once they fit into that, actually it's an unactivated one, but that's more, don't worry about it. They recognize each other, and then they're going to start spitting out this little shape into the world, into your bloodstream. Okay, so this is the plasma cell saying, oh, I recognize that. And then it's going to start spitting out this antibody, which fits in here. And then the killer T cells identifies that and kills them. It is way more complicated than that. And there are these CD markers that have to work, and don't worry about that. You'll learn about that in physiology or Bio 18 at Merced College. So let's talk about our white blood cell disorders. There are two major types. They're white blood cell cancers, or they can also be called neoplasms. Lymphoid neoplasms come from B or T cells, or the cells that make them. And basically, when you have a B or T cell neoplasm, you're going to have more or less B or T cells. Myeloid neoplasms result from basically a cancerous transformation from healthy cells to cancerous in the stem cells that make granulocytic, the granulocytes, the monocytes, red blood cells, and platelets. So the lymphoid neoplasms are, I wouldn't say necessarily like easier to treat, but they kind of are, because the lymphoid neoplasms only affect B and T cell types. So you can kind of zero in on the cancerous transformation more easily and knock it out with chemotherapy. If you have myeloid neoplasms, the myeloid neoplasms make all of your blood cell types. And so with a myeloid neoplasm, it becomes more important to just basically have an entire bone marrow transplant, which is really hard on the body. Multiple myeloma is a cancer where the B lymphocytes, which are called our plasma lymphocytes, start undergoing a cancerous transformation. It does tend to happen more frequently in people over 65, and it happens in the bone marrow. Part of what ends up happening is that the B lymphocytes start making defective antibodies. That's one of the diagnostic changes. So over here, what you're seeing in this individual is what they call this honeycomb or punched out bone defect caused by antibodies, inappropriate antibodies being made from B cells. And this is a cancerous B cell, plasma B cell. We know this is a plasma B cell because it has all these little vesicles that contain basically antibodies in them. And we know this is cancerous because it has 2 nuclei. Most cells don't have 2 nuclei. And in this particular panel, you have 1 and 2 cells that are cancerous. One that's plasma and one that one might be a T cell over on the left. White blood cell disorders typically are are characterized by individuals having anemia or recurrent infections, bone fractures, because the bones become damaged as a consequence of blood cell disorders. What's the treatment? Chemotherapy, drug antibody therapy can work well, bone marrow transplants, and stem cell transplants. The leukemias are a part of these blood disorders, white blood cells related to cancer, characterized by leukocytosis. They can be acute, really rapid development. So remember, acute's always happening fast, okay? Chronic is a slow development of systems. It happens over a long period of time, and it can either be lymphoid or myeloid. Remember, myeloid, in my opinion, but I think in general, most people would say myeloid is worse. White blood cell disorders, common types of leukemia would be your chronic lymphocytic leukemia. And again, this is something that you'll see in older individuals. It's really rare under the age of 30. Happens more frequently in men than women, which is a little unusual. It's diagnosed usually in a routine physical exam where a blood sample is taken. The symptoms are usually very mild, just kind of a little bit tired, somewhat anemic, but enlarged lymph nodes are very characteristic, but they're not painful. They're just a little bit fluffier, a little bit bigger. And so, the person kind of thinks, I'm coming down with the flu or something. Most patients can live for a long time with chronic lymphocytic leukemia. And basically, once it gets bad enough, and you can see here in this picture, all of the extra white blood cells here, right? Are they granulocytes or agranulocytes? Just take a quick look at this. Are these B or T cells? What are these right here? These little guys, remember? Not a lot of cytoplasm there. And so basically an individual can live with this for a long time. And so this picture is what we call a blood smear, showing lots and lots of diseased B lymphocytes. Acute lymphocytic leukemia, happens in children, and usually it's in younger children between 3 and 7 years of age. This type of what they call childhood leukemia is super highly curable in children, not quite as curable in adults. It's an acute onset, usually marked by fever, leukocytosis, which means you have a lot more leukocytes. There's bone pain, simply because there's so many white blood cells being produced that there's pressure on the bone. And there's an increase in infections, which is kind of crazy, right? Because you have all these white blood cells. Why aren't they working? Well, they weren't made right because they came from cancerous cells, so they don't do their job. They just float around causing problems. Basically, enlarged lymph nodes, spleen, and liver are very common because they get trapped in these lymphoid tissues, and the tissues are the spleen and the liver are trying to take care of them and break them down. Again, chemotherapy, radiation, and bone marrow transplants are common treatments for ALL. Chronic myeloid leukemia makes up about 20% of all leukemias, and this is usually the type of leukemia that you see in midlife, between 75 and 60 years old. Again, another cancerous transformation happening in the granulocytic stem cells. So in this picture, you can see granulocytes, lots of eosinophils here actually, full or this panel, this blood smear is full of eosinophils. The onset and the progression of the disease tends to be slow. Fatigue, weight loss, weakness are the initial symptoms. And again, basically, the disorder itself leads to spleen enlargement, also liver enlargement, lymph node enlargement, and can be treated with chemotherapy with Gleevec, and again, bone marrow transplants. However, one of the great things about this particular type of leukemia is if caught early, there's 70% chance that the individual will be cured. And then acute myeloid leukemia accounts for 80% of the leukemia in adults and 20% in children. So this can hit anybody. It's a acute, sudden onset, very rapid leukocytosis, fatigue, bone, joint pain again, because lots and lots of white blood cells are being kicked out. it does tend to lead to anemia because instead of making red blood cells, the stem cells start making white blood cells, right? So you don't have the red blood cells around to carry oxygen. And the individual is prone to recurrent infections and, believe it or not, spongy bleeding gums. This is not a very easy disease to cure. About 50% of children and 30% of adults achieve long-term survival. So it has a pretty high mortality rate. And again, bone marrow and stem cell transplant usually are what's used to help cure the patients. Sorry about that little flash there. I had a little problem real quick. So let's talk about a different type of blood disorder, infectious mononucleosis. Now, this is a white blood cell disorder that has nothing to do with cancer. Typically, this is the type of white blood cell disorder that will affect younger individuals between 15 and 25 years old. It's caused by a virus that hangs out in the saliva. And basically what happens is it affects the development and growth of white blood cells, making them look abnormal. So you could see this white blood cell is really large nucleus, and they typically aren't able to do their jobs. So infectious mononucleosis would take a normal lymphocyte here, like this guy, and turn it into, oops, let me get my purple pen again, turn it into that guy there. Lots more cytoplasm, a much larger nucleus, doesn't know what it's doing out in the bloodstream. So the individual will have lower immune function. Symptoms of infectious mononucleosis include fever, severe fatigue, a sore throat, a rash, enlarged lymph nodes and spleen. Generally, this resolves within about 4 to 6 weeks. And what what doctors typically do is just, if a student gets it, the student goes home, stays away from other people so that the disease can't spread, and just basically rests over 4 to 6 weeks. We're moving on to platelets and blood clotting, which is super important because once you cut yourself, you need blood clotting to stop the bleeding, right? Because you don't want to hemorrhage, lose all your blood. That would be bad. So platelets are the cell fragments that help facilitate clotting. So blood vessels, when they're cut, rely on platelet plugs, or basically a big net that fluffs up from fibrogen, to catch these platelets to form the clot. Accumulated platelets themselves release clotting factors which use positive feedback to increase the clotting mechanism. So in other words, once you get cut, those platelets start sending out signals to trap more platelets to cause a faster clotting reaction. And eventually the platelets are a part of the clot. So what's the clotting mechanism? Damaged tissue cells release clotting factors themselves, which leads to the formation of something called a Prothrombin Activator. This combines with the platelets themselves to start causing calcium to convert prothrombin into thrombin. So the platelets start making Prothrombin Activator. So you have a platelet, boom, okay, you have a cut, that's supposed to be a T, plus a plate, that looks like a red blood cell. Let me make something that looks more like a cell fragment, okay, a platelet, okay. The platelet's going to start secreting prothrombin, PTA, Prothrombin Activator, which then causes calcium, yes, ionic calcium in your blood, to produce thrombin itself, okay? So thrombin, R-O-M-B-I-N, there I am with my lovely handwriting again. Thrombin plus fibrogen then converts to fibrin. And I think I have a picture of fibrin for you. Fibrin looks like a net, and fibrin traps platelets, red blood cells, white blood cells, anything floating through there to form a blood clot. Here we go. So here's a much nicer representation of blood clotting. Let's say you're walking along and you step on a pin. Ouch, right? The damaged tissue is going to cause the initial release of blood out into the environment. So oxygen's out there too. Oxygen's part of this. the platelets start sticking together, and the prothrombin floating around in your blood all the time interacts with prothrombin activator and calcium to make thrombin. So you have the prothrombin plus prothrombin activator, PTA, plus calcium. Okay, these three things come together to make thrombin, to activate it. Thrombin and fibrogen come together to make fibrin, and fibrin is this yellow net here catching the red blood cells. So the red blood cells and platelets get caught up in fibrin, causing the blood clot. This is much better than what I just wrote. I should have just moved to the next slide. Sorry about that, folks. So platelets and blood clotting is basically a mechanism that keeps us from hemorrhaging. Altering the blood clotting mechanism, like by putting gauze over the cut, causes platelet aggregation, which causes the release of more clotting factors. So when you put pressure on a cut, you're keeping the platelets from escaping out, and it actually causes clotting to happen faster, all right? So that's a big deal. Sometimes when somebody has a very big cut or scrape, sometimes they will administer vitamin K, because that increases the production of prothrombin, which can also facilitate clotting. And then Coumadin is a medication that delays clotting by inhibiting prothrombin synthesis. So let's say somebody actually has really thick blood. They may be taking Coumadin to decrease the odds that in your bloodstream, the individual would be making blood clots because of the prothrombin potential. Heparin delays clotting by converting prothrombin back to thrombin. So heparin, keeps blood from getting chunky. Typically, when doctors are looking at blood, sometimes they'll have heparin in the tube so that they can do certain procedures without the thrombin forming. And then there's another medication called Tissue Plasminogen Activator, TPA, which is used to dissolve clots that have formed. And part of that has to do with getting rid of the thrombin-prothrombin conversion, or prothrombin to thrombin. So clotting disorders, hemophilia, this is an absolutely very serious clotting disorder. It's the most serious bleeding disorder in the world. It's an X-linked trait, so it's passed on from both moms and dads. But if an individual has one hemophilia gene, they might be okay. Two of them, very bad. And basically what ends up happening is this disease results in the inability to produce what we call factor VIII, a plasma protein. Factor VIII is a part of blood clotting. And so people with severe hemophilia who got two damaged alleles often have very severe bleeding, which can be life-threatening. A paper cut can be life-threatening. A bruise. What's a bruise? A bruise is breaking blood vessels and bleeding under your skin. All right? So you can bruise under your skin and not clot because in a hemophiliac, because blood clotting doesn't work, because factor VIII isn't working properly. It is characterized again by easy bruising, deep muscle hemorrhaging, really bad. Blood in the urine because the kidneys, there's blood in the urine because typically there's a bruise somewhere and the blood ends up escaping through the kidneys, or the kidneys themselves are damaged. Repeated episodes of bleeding inside of the joints. And then there can also be deformities in the skin and inside of growing bone. Oh, well, that's new and different. I've never done that before. I'm not sure what I pushed. Okay, platelets and blood clotting. Typically, to treat this, they administer factor VIII to help blood clotting to happen, right? Injury prevention, don't let them go outside. Definitely avoiding drugs like aspirin, anything that's a blood thinner or anything that interferes with blood clotting. And then one of the main treatments is the recombinant anti-hemophilic factor VIII, RHFF, which is a medication that eliminates the risk of the disease transmission, the risk of the disease based on genetic testing, and it helps the person along. Let's just put it that way. Helps keep them from hemorrhaging. Thrombocytopenia is caused by reduced platelets, the reduced number of platelets. Your body doesn't make enough platelets. Lots of bleeding happens here from really small blood vessels like capillaries, mostly in the skin, mucous membranes. So you'll see like bleeding of the gums, bleeding inside the mouth. Normal platelet count is usually 150,000 to 340,000 millimeters cubed volume, right, by volume. Typically, thrombocytopenia is below 20,000 per volume. And so this can cause really bad bleeding because there's nothing to trigger. First of all, you don't have the platelets to form a platelet plug, but secondly, they're not producing the clotting factors necessary for controlling a hemorrhage. So the most common cause of these diseases would be usually a genetic dysfunction. So bone marrow destruction by drugs, chemicals, radiation, diseases, cancer, lupus, HIV, AIDS are also common in making thrombocytemia. And then the treatment, well, you can actually get a transfusion of platelets, which works really well. Corticosteroid drugs or the removal of the spleen, because the spleen destroys platelets. The spleen gets rid of those items. By removing the spleen, you'll maintain more platelets. All right, that's it for the blood system.